So I'm going to talk to you about the heart sink patient who none of us want to see in the clinic. I work in Rahman Medical Institute in Peshawar, and occasionally I visit Karachi because I love Imran so much. These are my disclosures which are relevant to the talk. Happy or unhappy, this is a term which we see quite often. I leave that for you to decide which one's happy or unhappy, but this is a mirage, so don't be fooled by it. Um, we all know that everyone says that it is the best operation for knee replacement, and if it was, we weren't going to be having this meeting and controversies being discussed. The indications are obviously ever expanding, but we do still see a significant number of patients who are unhappy with the outcomes of the knee replacements. And most of these patients, mind you, are those groups of patients where we struggle to find a cause. And the only thing which most of us do is keep sending them back home, thinking that after 6 or 12 months, they'll come back and their knee pain might have improved. So let's delve into this and have a look. So we all know that this is one of the most common complication after a knee replacement. And I think part of it is because one of my previous colleagues also mentioned these pictures, social media, it is being displayed as the operation where, well, eventually you will climb a mountain. I don't know of any of my patients who can climb a mountain. Some of my hip arthroplasty patients have sent me pictures. One recently who climbed Miranjani peak and said, Dr. Saab, you did say, okay, I can climb peaks, and here you go, here's the picture. Anyhow, so it is these sort of pictures which do fool some of the patients. So here's a diagnostic algorithm. This is how I look at it. And I think the most emphasis should be put on history and examination, and that will give you some insight into a probable cause for this pain. So let's look at everything in detail. When you look at history, get hold of all the previous medical notes, see if they've had any previous surgeries. I do know that there are certain papers which suggest that if a patient has had an intra-articular injection or a previous arthroscopy for arthritis, they don't do as well as a virgin knee, if you may call it. Comorbidities, we've talked about yellow flags, and the yellow flags are depression, hypothyroidism, and patients who've been using opioids chronically. These are the high-risk patients which, when they come into your clinic, you need to look into and, be aware of them, that in case they turn into your clinic again, so that might be one of the causes. Expectation versus reality, that is another important thing. We need to be very, very realistic with our patients. Females, it's already been discussed, asymptomatic UTI is not a contraindication to a knee replacement, but there is a tendency as they grow old for them to have recurrent UTIs. Obviously, we're never to be blamed for a failed knee replacement, so it's one of the cause for it. Over-enthusiastic activities, it's been mentioned in the literature, but I don't think our general population is the over-enthusiastic lot. With navigation and robotics, spin sites, pain, that has also been reported. One needs to be aware of it. The rest of it I've already mentioned. So clinical examination, we must check them for gait, if there's any thrust which might point towards instability, any previous scars, skin changes. An atrophic skin might point towards a vascular cause. Shiny, red, hot, warm skin might point towards RSD or CRPS, so be aware of it. If there is any change in the gait, whether they might have in-toeing or out-toeing, I hope none of my patients get that, but be aware it might be a rotational abnormality or component malposition, which can be confirmed on CT scan. There are certain patients who might have early PVNS, which one might miss, and that can lead to recurrent hemarthrosis or effusions. If there is component overhang, that might lead to medial or lateral side tenderness, and PFJ issues obviously discussed. So I'm going to put a case in front of you. This is actually the mother of my accountant who's been looking after my accounts for the last 2 years. This was, so this was the pre-op X-ray of his mother who had knee pain. Had no MRI scans based on these X-rays, had these knees done simultaneously. And after a year or so, she continued to have the pain. And by that time, I was one of his clients. So he brought his mom to my clinic and said, my mom's knees still hurt. So I went back to the basics, took a detailed history, and no surprises, this is what we found. So I referred her to our local neurosurgeon. She underwent release for this stenosis. She comes back and gives me a hug. Beta, you're the best thing that has happened to me and all that. For a year or so, she was fine. And then she came back and said, my left knee is hurting again now. So this was about 2.5 years post knee replacement. So I then proceeded, did some bloods. Her ESR, CRP was slightly elevated. We did a bone scan, surprise, surprise. She's now got an infected left knee. Now, I do not know whether that was infected from the very beginning or whether that was a hematogenous spread or something. The question I want to pose to the audience is whether anyone would have done a knee replacement at all in the first instance. So history is very important. Types of pain, again, it's a very important slide. I'm not going to go into the detail of it, but the type of pain may point towards the cause. Precise localization, we all talk about precise localization, but we all know that knee joints are a very difficult joint. Patients find it difficult to pinpoint towards the exact area. It's very difficult for them, particularly with the soft tissue injuries. And referred pain, please, 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 when you examine your patients, put them on the couch, examine their hip, examine their spine, and for diabetic patients, make sure you check their distal vascular status as well. A few important things, if the post-op change has remained unchanged from the pre-op, then think whether the indication was right. It might be referred pain from somewhere like I showed you from the previous case. Post-op pain in the very early stage might be infection, maybe instability, malalignment, leading to soft tissue impingement as well. Delayed onset pain could be due to septic or aseptic loosening, which leads to polywear and eventually partial ligamentous instabilities as well. Psychological exploration is very important. Depression, hypothyroidism, opioid users, all of these. Then there are a group of patients who, I was trained in Leicester, so we used to have a lot of Gujarati patients who would have a perfect knee replacement done. You ask them, do you have any pain? No. How much do you walk? I can walk miles. Are you happy with your knee replacement? No, I'm not. This is what they would respond. And one of my bosses used to say, these are the patients who have total body pain. They never get better. So this is where I get that from. Plain x-rays, they do give you a lot of information. Obviously, you need to have a system for that, like you have a system for analyzing any x-ray. Bear in mind those static lucent lines, they will be insignificant. Do not be alarmed by it, but it has to be on serial radiographs. This is a patient, 12 years post-op, had a knee replacement done at another center. But what I want to point to is this bit here, not Imran's head. These are signs of loosening, early loosening, but this was 11, 12 years post-op. Certain technical points, if your tibia loosens, mostly it shifts into varus, and the femur, if it loosens, mostly it shifts into flexion. Classical signs of septic loosening on radiographic analysis. Overhang, your plain radiograph will tell you. Clinical examination will point towards it, and you can do local infiltration tests under very aseptic, sterile conditions to confirm the diagnosis. Anterior knee pain, we all talk about patella, whether to do it or not to do it. This was a patient who had a knee replacement done, and the patellar button was loose within 18 months. CT scans, the best utilization for them is in your primaries is to check whether there's component malalignment, and if there is any difficult case like one of my colleagues showed, to assess and check for any bony defects to plan your surgeries. We all know about bone scans. Just a reminder for this, please don't do them in the early stages because the bone remodels. So if you have to do them, think about at least 12 to 18 months. Lab tests, we all talk about ESR, CRPs, you have to take everything into consideration and combination. Interleukin 6 is a far better test, and evidence suggests that a combination of interleukin 6 and CRP are perhaps more sensitive and specific than any of the other tests. If you are in doubt, take them to theater, aspirate under strict aseptic conditions, various tests, various methods. Make sure you send them in your blood culture bottles. If you grow different weird kind of bacteria, think if there is a contamination, and if you think there is a contamination, repeat the process. Make sure you have a musculoskeletal microbiologist or a microbiologist who knows the bacteria around where you work. Instability or mid-flexion instability, more importantly, is something which has been considered and discussed from 2005 onwards, various causes of it. One of the commonest causes is an over-exuberant cut in the proximal tibia. Stiffness, how do you define it? We don't know. There is no definitive stiffness definition for it. But again, this is something worth considering. Allergy, whether this is a myth or a reality, we don't know, but it's something which has been discussed. This is a very nice systematic review looking at both intrinsic and extrinsic causes for knee replacement. So it is available to all of you. You can have a look. So what is an unhappy knee? We do not know. I think it is that knee after you've applied your diagnostic algorithm and you still do not find a cause. This is probably the unhappy knee. The thing what I would suggest you don't do is, unless you find a definitive cause, do not expose them to a revision knee, because they will continue to be unhappy. So I come from the north. I would like to invite you to come and visit us. Lots of lakes in Yasin and Ghizar Valley. This is the mighty Nanga Parbat. We have the very old Indus civilization, and in the backdrop of Buddha you can see the mighty Indus River. This is from Skardu. Imran knows this place. This is Tarbela Lake or Tarbela Dam, as you might call it. Deosai Plains, 14,000 species of flora and fauna which you will not find anywhere else. And the Shangri-La or the Upper Kachura Lake, the Lower Kachura Lake. Thank you very much.